Welcome, everyone. We're so excited to have you here for a live Q&A with Dr. Daniel Miranian, where he will demystify one of the most talked about topics in fertility care, IVF success rates. If you have any questions of your own, please feel free to use the Q&A comment box to submit them at any time, and Dr. Miranian will answer as many fertility questions as possible. And now, without further ado, I'll pass it over to Dr. Miranian to get us started.
Awesome. Thanks, Emily. Hi, everyone. I'm Dr. Daniel Miranian, a reproductive endocrinologist and infertility specialist with RMA. I'm based out of Philadelphia. I see patients in person at Center City and our King of Prussia or Wayne locations, but I also do telehealth. Just want to welcome everybody who's joining virtually. And for those of you that are watching this after the fact, welcome as well. And I hope you find this valuable. So today I'm going to just start by giving an overview to try to help everyone at home understand IVF success. And then we'll launch into the Q&A at the end. So whenever I'm seeing a couple, one of my goals is to help them understand what success looks like. IVF is a process that's really evolved over the years. And back in the day, IVF success looked like just getting pregnant, but now we are getting better and better at IVF, and we've raised the bar from not just getting pregnant, but trying to get our patients pregnant in a way that's safe for them, safe for their pregnancies, and also in a manner that's both time and cost effective. By the time couples see me for their initial consultation, most of them have been thinking about or trying to plan their family for quite some time. So we want to also take into account, the time aspect of things. And so I always love to start by, trying to understand how big of a family a couple is trying to achieve and really tailor my approach to helping them reach those goals. And so when we think about IVF success, a lot of times you'll only be looking at one single pregnancy at a time. But that's where it's important when you're meeting with a reproductive endocrinologist to have them, take into account really what your long-term goals are, not just, one pregnancy at a time. The other thing that we won't have a chance to really talk on too much, but I think is worth acknowledging is that, there are obviously objective measures of success when it comes to IVF, but there's also some more subjective measures like how you feel in the experience, how well informed you are about the process, and that's something that I really try to make sure that patients feel supported as they go about their fertility journey. So I keep mentioning these objective measures of success, and that's what I'm going to spend a little bit of time talking about now. Generally, when we talk about IVF success, obviously everyone thinks about a take-home baby, but there's a couple of things that we need to understand before we look at that. And so one way that you can actually find a lot of information about potential fertility clinics is through a national organization known as SART, which stands for the Society of Assisted Reproductive Technology. And SART has a website called sart.org or SART.org. And if you go to their website, at the very top, you can click IVF success, and then under that, find a clinic. Once you're there, you can search either by where you're located or if you have a specific clinic in mind. And then from there, you'll see all sorts of outcomes that are grouped by patient age range. Now, this is an important feature to take note of, because if you're comparing yourself to somebody that's significantly older or younger than you, what is an expected success rate may vary. Unfortunately, as women get older, not only do the number of eggs they have decrease, but also the quality tends to decrease. And that's why it's important to kind of look at somebody in your similar age range when looking at success. So the very first category just gives you information about the number of retrievals a clinic is doing, the percent of cycles that were canceled, and then the mean number of eggs and embryos that were created. You'll oftentimes see the embryos referred to as a blastocyst, and that's what we're going to be talking about today. The blastocyst just means a mature egg. Usually it's grown out in the lab for 5 to 7 days. If you scroll down further on that landing page, you'll see another category looking at live birth rate per frozen embryo, and specifically the blastocyst embryo is what you're going to be looking at. And we have the ability to test embryos to see if they carry the correct number of chromosomes, what we call PGTA, or pregenetic testing aneuploidy. And you also want to look to see the success rates for either an untested embryo, if you're planning to put back an embryo that's not been tested, or an embryo or blastocyst that has undergone the PGTA testing. Typically, the success rates for a genetically normal confirmed embryo is going to be higher than the success for an untested embryo, but that's something you can look at each clinic. Ultimately, though, what I find the most helpful when thinking about your chance of success is to look for the live birth rate per egg retrieval, because that's going to give you the most information about what your actual chances of success would be. And unfortunately, this is buried on a different page at the top. If you click under View Detailed Report, then you can find the information about live birth per egg retrieval. And that just tells you what percentage of patients in your age range had a live birth for that egg retrieval. The other thing you'll see on that page is the live birth per new patient. And that tells you, of people that stuck it out, they may not have been successful and had a live birth their very first egg retrieval, but if they continue to pursue treatment at that clinic, what the chances of having a live birth are. So I think those two measures are actually the most relevant to patients when they're trying to locate a fertility clinic to go to. And lastly, you can also compare the values or ranges to national averages. At the top banner, there's a option to look at national data, and that's sometimes helpful to see. The next thing I want to spend a little bit of time talking about is, what factors actually drive IVF success. I'd say the number one predictor of success is a woman's age when she presents to care. And then the next most important would be her ovarian reserve, roughly the number of eggs she has remaining, or how sensitive the ovaries are to injectable medications that we use in the IVF process. Unfortunately, those are two metrics that we can't influence or change, but there are a couple of things that are potentially modifiable. And one is the IVF laboratory that you go to, and that's where selecting a clinic that has a high success rate can make a difference in your chances of getting to the ideal family size that you set out, as well as the time that it takes to get there. The other things that may make a difference but aren't going to move the needle as much as those other factors would be the stimulation protocol that your fertility specialist recommends. And this is where sometimes going through the process multiple times, we learn from cycle to cycle how to optimize for your specific body. The other thing when we're talking about live birth, IVF is really a two-part process. The stimulation part where we get the eggs, but also the second part is when we transfer the eggs back, or transfer the embryo back, the embryo transfer process. So the protocol your fertility specialist selects for that can also make a difference. And then lastly, a thing that patients ask about frequently is adjunctive treatments that we have to offer as women go through the IVF process. This at most may increase the number of eggs by 1-2 per cycle, which is not insignificant, but it's not going to move the needle as much as some of these other factors that I mentioned. So taking this all into account, one of the reasons that IVF success can look different from patient to patient can be any number of those factors that I talked about, as well as the actual fertility diagnosis or cause of them having infertility. That can make a difference in somebody's chance of success. So it's important to kind of keep that in mind when you're looking at these predicted chances of success. And ultimately, there's a big amount of luck that comes into play as you go through this process. But what I would say ultimately makes the biggest difference on whether somebody ends up with a take-home baby, so to speak, from the IVF process is going to be their cumulative engagement and care with the fertility clinic. So I wish it was as simple as seeing patients through the IVF cycle once and then them getting their ideal family size just from that. Sometimes it works out that that's the case, but oftentimes this is an iterative process. I tell my patients all the time, fertility treatment is a marathon, not a sprint. Obviously, by the time you come to see me, you're eager to just sprint across the finish line, but you really have to think about the long-term treatment and pace yourself accordingly. This is a sometimes very physically, emotionally, financially taxing process. And my job as a fertility specialist is to help guide you, be prepared for this journey, and take you along as you go about your family building um, journey. And so, ultimately, I hope that you are able to take this information and it may be useful to help in guiding you through selecting a clinic, but ultimately, in order to think about your chance of success in a way that's really personal and realistic, I would recommend consulting with a fertility specialist, because ultimately that partnership is going to be important for you as you go throughout the process. So with that, I'll pause for now, and I believe we already have some questions in the chat. I'll turn it back to Emily, and I think she's going to read the questions.
Yeah, thank you so much. That was fantastic. So we have a few questions here. The first one is, how does a woman's age impact the likelihood of success?
That's a great question. And I didn't go through each of those age categories, but generally the older a woman is, even if she has the same number of embryos, the chance of that embryo being genetically normal decreases as women get older. So if you're looking at putting back untested embryos, the chance of having a live birth does decrease as you get older. Some people hear about, the fertility decline as being some sort, as a cliff. The reality is there's not a cliff that happens as you turn a certain age that suddenly your chances of getting pregnant disappear. But there is a gradual decline as women get older into their mid-30s. And certainly by the time they're 40, the chance of success does decrease. And that's where sometimes it does require multiple cycles to go through. And consulting with a fertility specialist will be able to kind of put that into perspective.
Great. So just basing off of that, can you just answer how many IVF cycles does it typically take to achieve pregnancy?
Yeah, I wish I had an answer of like, you need exactly, 1.7 cycles to achieve a live birth. Again, that's where it really depends on how old you are going into the process, what your ovarian reserve looks like, and the underlying diagnosis. There's certainly some couples that go through and are able to get pregnant and build their entire family with one cycle. But I would say, oftentimes it does take several rounds of treatment, even just to get one live birth. At times, we're eternally optimistic, but we also want to be realistic with chances. And I wish I could give a more specific answer, but I'd have to have more information.
Great, thank you. And we have another question here. Is it generally recommended to wait 1 year before visiting a fertility clinic like RMA, or can someone go earlier if they believe there may be an underlying issue?
Thank you. That's a really great question, and I think a commonly misunderstood part in this process. We historically have said that if a woman is under the age of 35, that they meet the definition of infertility if they've been trying to achieve a pregnancy with regular exposure to sperm for at least a year. And then after 35, we know that the chances of a woman getting pregnant decrease as she gets older. So we cut that threshold in half to say try for 6 months. However, if a woman's not releasing an egg or ovulating every month, it doesn't matter how long she's tried. She may have a 0% chance of getting pregnant. So a common condition that we see is women with PCOS, or polycystic ovarian syndrome, and a lot of those women don't ovulate regularly, and that would be a reason to see a fertility specialist without waiting that predetermined period of time. And ultimately, it's up to the couple. If they've been told they may have a condition like endometriosis or fibroids, it may be worth consulting with a fertility specialist sooner rather than later.
Great. How do frozen embryo transfers compare to fresh transfers in terms of success?
That's a great question. So again, historically, as I mentioned, we used to put back many embryos at a time and only did fresh transfers. And that was in part because the chance of IVF being successful was lower. Unfortunately, that led to a lot of twin and triplet pregnancies. However, as we've developed better techniques of growing those embryos to the blastocyst stage, as well as freezing them for later use, we found that the chance of success is actually comparable with a frozen embryo transfer compared to a fresh transfer. There can be certain situations where your fertility doctor may recommend a fresh transfer, but in general, we think that the chance of success is comparable. And by going and freezing all of the embryos up front and then subsequently focusing on the embryo transfer cycle, it gives us more flexibility and understanding of how we can optimize your uterine lining and preparing your uterus to receive and accept an embryo.
Great. So I have a question here just about, let's see, in between failed transfers, how long should you wait? Is there a recommended time that you think that people should wait?
That's a great question. I would say there's two answers to that. There's obviously always a lot of hope going into a transfer cycle, and naturally, if it's unsuccessful, a lot of disappointment that follows. And so emotionally, some couples or patients need some time to get to a point where they're ready to move forward with another transfer cycle. If a patient is unsuccessful and doesn't get pregnant with a transfer, we can move into preparing for another transfer cycle as long as they have remaining embryos right away. However, if somebody gets pregnant and has a miscarriage, that may be a situation where we have to wait for the miscarriage to resolve, get another period, and then prepare for an upcoming cycle. And that's where there can be some variation between how quickly you can move into another cycle.
Great. The testing for the partner on the male side, can you go into a little bit about that and what they might experience coming to RMA and coming to your fertility clinic?
Sure. So it's rather cruel that the testing for women is a little bit more involved and certainly there's already some discrepancies from the onset. I know a lot of women feel the burden of starting a family. They really take that on themselves. But when we talk about the male side of things, we typically start with what's called a semen analysis, sometimes referred to as an SA. And essentially, it's looking at a masturbated semen sample to see if there's sperm in the ejaculate. Usually, we're able to quantify that. It's a normal number would be somewhere in the millions. And then we also look at how well that sperm moves, and then how the sperm actually looks, what is known as morphology. And we kind of take that all into account. And whenever couples are trying to build their family, we're also checking to make sure that they're healthy, they're not carrying any sexually transmitted infections that could impact a pregnancy as well. So those are the two things: the semen analysis and the infectious testing that guys have to do. So for anyone listening at home, if you have your male partner either listening, or you can reassure them, it's not as bad as it sounds. It's a very quick procedure. And actually at RMA, we allow patients to produce an ejaculated sample in the comfort of their own home, as long as they can bring it to our clinic within 1 hour. So really, guys, we have no excuse. The ladies are doing all the hard work. We need to step it up.
Great. We have another question based off of your answer. So let's say the semen analysis comes back and it's irregular. What happens next? What's the best move for that patient?
Yeah. So typically with one abnormal semen analysis, it kind of depends on what the finding is. But generally, my first step is to repeat the semen analysis. There's always a chance it could be just a one-off event. But if once we repeat the semen analysis and it looks like there's a persistent issue, whether it's not enough sperm, the sperm's not moving in a high percentage, or certainly if there isn't any sperm at all in the ejaculate, that's a situation where we would recommend meeting with a reproductive urologist. So sort of a male, a doctor that deals with male fertility, the equivalent of I'm a female fertility specialist, but they're able to do a much more in-depth evaluation of the male partner, look at their medical history, their potential exposures, do a physical exam, because sometimes there can just be a matter of some physical abnormalities that can make it harder for guys to achieve a pregnancy. And we work very closely with a male urologist in our clinic here in Philadelphia. And that's something that your fertility specialist would be able to point you to wherever you're located.
Great, thank you. And so let's say someone's just starting out and they aren't sure what they have to try first. Do you always recommend trying IUI before IVF, or does it depend on the patient?
That's a great question. The short answer is it depends. Certainly, the thing that I look at, there's two things that I kind of take into account. One is how long the couple has been trying. If they've been trying for years and years and years, sometimes it's a hint that IUIs may be less successful, but not always. It depends on the underlying diagnosis. The other thing that comes into account is a woman's age. So we have good data from randomized studies looking at the likelihood of achieving a pregnancy, as well as the time it takes. If a woman is over the age of 40, the chance of achieving a pregnancy through IUI is decreased significantly. And in those cases, we recommend moving forward with IVF straight away. Less than that, it often depends, and that's something that your fertility specialist can talk to you about in more detail. And then the other thing that I wish wasn't the case, but a lot of times these decisions, as I mentioned, come down to the financial aspect of things. So some fertility insurance, a lot of patients don't have any fertility benefits whatsoever, but some that have fertility benefits require a certain number of IUIs before moving to IVF. Unfortunately, if you look across the board, IVF is a much more successful treatment than IUIs. So some fertility benefit plans are actually moving towards covering IVF right off the bat, even in those younger patients. So that's where seeing a fertility specialist and having them look at the whole picture can be really helpful in trying to navigate those types of decisions. And then the last thing I would mention is, this is where it's really helpful to know how big of a family you'd like. Because if a woman, let's say she sees me at age 34, but wants to have 4 children, we may be able to get her pregnant with 1 child through IUI, but you don't have the ability to bank embryos for future use with IUI. So that may be another indication for going forward with IVF right from the onset.
Great. After a successful transfer, the success rate for a second FET, does it change because you've had a successful transfer? Is it the same? What can you speak to that?
Yeah, so I'm gonna just because I know we have a lot of different listeners out there, You mentioned an FET. That's an acronym that we use that stands for frozen embryo transfer. And that's different from like a fresh embryo transfer. So I just want to make sure, Emily, you're asking what if somebody had a successful transfer, is there a chance of having another transfer more when they come back for maybe, let's say, their next child? Great question. So I would say, in general, we're optimistic if somebody's been able to achieve a pregnancy once, that they're likely going to be able to achieve another pregnancy subsequently. But some of it depends on how the pregnancy itself actually unfolded. So if a woman ends up with a complicated pregnancy and needs a C-section, we always want to re-examine the uterine cavity. Sometimes, not all of the time, so I don't want people to be concerned if they have a C-section that they won't be able to get pregnant, but we always look to see how the C-section scar actually healed. Even if a woman has a vaginal delivery, there's always a chance there could be scarring on the inside of the uterus or other things that come up in between as a woman gets older. And so at our clinic here at RMA Philadelphia, we always do what's called a hysteroscopy, where we look inside the uterus with a camera to make sure that the uterine cavity is as pristine as possible to accept another embryo.
Great. I think we have time for a couple more questions if you're okay with that.
Absolutely. Yeah.
Going back to SART, we have a question here. When looking at the SART reports, why is the most up-to-date reporting period 2022 with a preliminary report available for 2023? How reliably applicable are these data to 2026?
Awesome question. Very astute. Somebody was looking in real time as I was describing how to go about finding this information, and I'm glad you asked. So one of the reasons there is a delay is you can look by actual year that the cycle took place. But as we all know, there's a 9-month delay from when somebody gets pregnant to delivery. It's actually less than that, but there's a delay from when you get pregnant to delivery. So we need to allow some time for those outcomes to actually occur. The nice thing about the data that you'll find on the SART website is it's been curated, or it's been validated to make sure that the data is reported accurately. So it takes a little bit of time for that to come through. So oftentimes, you'll see a couple of year lag from when the data is reported to where we are now. And generally speaking, you can look back at a couple of years and see if there's been any major changes. There can be things that happen with staff turnover that could impact success rate. But generally, if you look back at the most recent data, that's going to give you the best predictor of how that fertility clinic is going to operate and chances of success.
Great answer. That clears it up for me too, because it's always curious. You're always curious of why they do that.
Yeah.
We have time for one more question, and this question is about stress and success rates. How much does stress impact your ability to get pregnant when going through infertility treatments?
That's a great question. I want to be clear. There's a lot of information about how stress can impact your chances of getting pregnant. When it comes to once you've reached the point of doing IVF treatment, there hasn't been any association with like the amount of stress a woman is under and their chances of getting pregnant. Meaning that it's not like the stress itself is going to prevent you from having a successful outcome. The time where stress can come into play is if you get to the point where you're so stressed out about the process that you aren't able to continue on with treatment. And it is a stressful time to go through. And a lot of clinics have support systems in place to help couples, especially if they've gone through multiple cycles and they have a bad outcome. We have a social worker that works with our clinic that is phenomenal at meeting with patients, spending time, helping them through what they're navigating. I wish it was a linear, straightforward path, but sometimes it's more of up and down. There's, the great thing about my job is there's the highs of high, but there's also the lows of lows. And nobody feels that greater than the patient that I'm taking care of. And so it's really important that you're doing things to take care of yourself, physically, emotionally, mentally. I know this process, a lot of patients are scared to share with their significant others. They're afraid of how they'll be perceived or if they'll be judged. And it's different for everybody, but there are ways to seek support as you go throughout this process. And so, I wish everybody the best on their journey. And I really thank everybody for taking the time to listen in today. It's been great to hear the questions coming in.
Yeah, thank you so much, Dr. Miranian. We really appreciate you being here. And thank you everyone for the amazing questions. Follow us on Instagram and Facebook. We'll have some more we'll have some more of these coming up in the next few weeks.